unquestionably the best cardiac surgeon throughout the Bay Area, one of the best in the country and if not the world. The only thing about Dr. Gaudiani is he's been practicing now for about 34 years, but he started when he was 20. And as you'll see, you know, he's a shy guy, so don't press him too much. But without a doubt, a great resource for El Camino Hospital and our community is to have not only the physician, but the man, Vince Gaudiani, on our team.
So Jim just gave you a really good introduction to the most advanced, and in some ways the most interesting part of aortic valve replacement. But there's a long and interesting history of where aortic valve replacement started and actually where the best of it is still today. Because despite all the advances that everybody's trying to make, if you're able to undergo an operation, the safest, lowest mortality, lowest risk of stroke, etc., is small incision aortic valve replacement that's done under direct vision. The problem, of course, is you have to have a cut put on you. But one of the ideas that is not mentioned enough is that minimally invasive or less invasive, the quality of the outcome is very important. So not just how big a cut, you get over the cut. The quality of the operation is what you live with. So let me tell you a little bit about where it was, because in almost everybody in this room was alive when there wasn't any aortic valve replacement. And I can, for some crazy reason, I can remember Walter Cronkite in the 60s talking about, you know, early valve operations that were done in Houston and in various places before we even had good prostheses. So I'll just show you a little bit about that. The first thing to do, though, is to tell you what the aortic valve does. It's the last one-way check valve before blood that's been oxygenated in the lungs leaves the heart and enters your body to deliver nutrients and oxygen to your tissues. And it's got a phenomenal job. It opens and closes 100,000 times a day. So if you do the math, it's 36.5 million cycles a year. 360 million cycles every 10 years. I mean, that's a lot of cycles. And that's just 10. And then for a normal-sized person, somebody my size, I pump, just sitting around doing nothing, I pump about 7,200 quarts a day through my aortic valve. So, you know, they're between 5/8 of an inch and an inch across, so they're quite large. And a big football player would pump easily 8,000 just sitting still. At rest, guys my size pump about 5 quarts a minute. And at peak exercise, even at my advanced age, I can get into the low 20s, 20 quarts a minute. So you have 5 quarts of blood in you. Some of you have heard me tell you this in the office. You have 5 quarts of blood in you. So just to sit around, all your blood goes through each pump once a minute. At peak exercise, I can get it to go through 4 or 5 times a minute. And somebody who is a world-class cyclist can get all their blood through their heart every 6 seconds, you know, get into the 40 quarts a minute range. So it's a phenomenal piece of equipment. And your valves, of course, the reason they're there is because if you think about what nature had to deal with, she had to have a squeezing kind of pump, and the only way that would be efficient is if it had one-way check valves in it. When it gets in, it can't back out. When it goes out, it can't fall back in. I mean, each pump would have to have that. And, of course, we do. So the major cause of failure, Jim showed you a typical one, I'll show you another, is that as we age, for some reason or another, your body responds to low-grade injury by calcifying it. So all the men and many of the women in this room who've done sports or handled a shovel will have calcium in their neck muscle, for instance. And I can't turn my head as far as I could when I was 20, that's for sure. But of course, that doesn't matter. You know, you can still get through life and be fine. When it gets on your valve, though, this thing that has so many cycles to do every day, it can hugely affect the way your heart works. Body also responds to slight congenital abnormalities over time by calcifying them. So if you didn't end up with a perfectly constructed aortic valve, but one that was just good enough, by the time you're in your 50s and 60s, it may have been sufficiently calcified so that it won't work well anymore. And less commonly, of course, rheumatic disease. And by the way, some people, whoever asked about scarlet fever, Some of the scarlet fever stuff was an acute inflammation with a streptococcus bug. And that the strep bug, there are a couple of strep bugs that on their surface share a protein. The protein has a similar appearance to a protein that's on heart valves. So if you get a strep bug in your throat and you don't get penicillin, your body makes antibodies to that strep bug, and they accidentally cross-react with the ones on your heart valves. And so your own body attacks your heart valves. And once that attack begins, it starts the scarring process that goes on for life. And in the 50s in the United States, there were hospitals full of people like this. There still are in India. And some of the most experienced guys in the world of dealing with rheumatic valvular heart disease are in India. We still see them because a fair number of them, Conrad and I and others, we see a fair number of them because there are so many people here on the West Coast from places that are originally third world countries, or when they were kids, they were a third world country, and they may not be anymore, Mexico, Vietnam, etc. The Fiji Islands, India. So, and then so that disease is really a friendly fire disease. It's not really an infection, but there are actual infections called endocarditis that we have to operate on every now and then. So there's one. This is a typical rheumatic valve. You wouldn't mistake this, just a completely typical rheumatic valve. And you can see that, you can see that the hole gets reduced by the thickness of the scar. And one of the most interesting things about this is that in the 19th century, there was a physicist who tried to figure out what would happen to flow. If, let's say, you're flowing through a lot of water through a pipe that's got a diameter of 6 inches, and you want to know how much the resistance to flow would go up if the diameter is reduced to 3 inches. So if you install half a pipe half the size, how much does the resistance to flow go up? How much more work do you have to do to push the fluid through a pipe that's half as big? And of course, obviously it goes, as the pipe size gets smaller, the amount of force you have to put on the fluid to push it through goes up. But it goes up as the 4th power of the radius. So if you make the radius half as big, it's a half times a half times a half times a half, or it goes up 16-fold. So, and that's why aortic stenosis is such a serious disease, and why it always, as Jim was saying, it always ends up killing you. Because as the calcium gets bigger in the valve and the hole gets smaller, the resistance to flow starts skyrocketing because it's a 4th power function. And so at some point or other, and this, by the way, is the exact analogy to this, is the strongest man in the world lifting a weight. If it's 100 pounds, he can do it all day long and it doesn't bother him at all because he's got such great muscles. Just start adding stuff on either end of that bar, and no matter how strong that weightlifter is, eventually, he'll drop the bar. And for people with aortic stenosis, dropping the bar means that your heart just can't pump blood, and you can't get enough blood to your brain, and you hit the floor. So there's another way the valve can fail, though, besides getting narrowed, and that is, since it really is made of 3 pockets, just like my shirt pocket, 1, 2, 3. These shirt pockets, where is the stress when I when I stuff blood into a shirt pocket, where is the stress, boys and girls? It's obvious, it's right here on this suture line. And so the aortic valve can tear here, and that tearing causes aortic regurgitation. And that tear can be because the grand designer didn't give you quite as good a valve as the next person to begin with, and you happen to outlive it. It can be a function of a congenital abnormality of the valve. It can be a function of age. So we see some patients with aortic leak, and those people are like the people with aortic regurg. The valve opens widely, but it doesn't close properly. So it shoots a bunch of blood into your aorta, and half of it falls back down inside. And so you're like a guy at the bottom of a sand pit shoveling. Every time you shovel, half a shovelful falls back down in a hole. Those kinds of things make the heart bigger. The heart gets larger as it has to do more work. But as the inside of the heart gets larger, the grand designer does not give you additional muscle to squeeze with. So now think, that same rind of muscle that's around the heart starts thinning as the muscle as a whole gets larger, and you get a crummier and crummier piece of equipment to pump with. And that's why it's important to replace valves that are leaking when the leak gets bad enough. So in order to replace an aortic valve, a huge history of technology was developed, starting with the development of the drug that allows you to anticoagulate blood so you can run it through tubing. That drug is called heparin. It's actually something we all make every day. Our pancreas makes it. A medical student in the 30s figured this out, and heparin was purified from that, and now it's purified from pig pancreas. Without that, we wouldn't be able to go on the heart-lung machine. But then, of course, you need a heart-lung machine, and the cardiopulmonary bypass machine is a development of the 50s and 60s. Again, most of us were alive when, most of the people in this room were alive when that was developed. The founder of IBM, Watson, contributed mightily to this with engineering help. This is in Philadelphia in about 1954. Then, of course, anesthesia is extremely important in this. Great anesthesia. Conrad, have we ever seen great anesthesia? No, I'm only kidding. We always make fun of our anesthesiologists. It's just a long-standing thing. But you've got to have, if there are any anesthesiologists here, shut your ears. You've got to have great anesthesia to do this, and we have great anesthesia here to do these cases. And they're part of this greater team that Jim also talked about. You need a bunch of people that are really on the same program that you're on and want to.
Be careful, you're wearing a wire.
Yeah, well, they're not going to make a copy of this, are they? Because I'd be drummed out of the society if anybody heard me say nice things about anesthesia. You die. You're a surgeon. You've operated all your life. You'd like to go to heaven. So all of a sudden, the door opens. You're in the operating room. There are beautiful nurses. The patients on the table are prepped and draped. They hand you a knife. You look across the ether screen. There's no anesthesiologist there. You went to heaven. There's 2 anesthesiologists there. Guess what? Now, I just wanted to get that in there. So you need safe blood bank, of course, and that's another miracle of our modern ages. As you know, again, we all know that from the AIDS epidemic when we did not know that it was a bloodborne disease. And there was a lot of other diseases that weren't understood in the time before AIDS. But now blood transfusion is extremely safe. So you not only need a good team and a reasonably talented surgeon, you also need a safe replacement piece of equipment. And this technology goes back a long time. There were basically 2 kinds. Some were mechanical, and these were made out of material that's not biological, that is, that doesn't come from an animal, or including man, by the way. And then there were tissue valves, and tissue valves come from human tissue. Someone who's sustained a lethal injury and their heart isn't good for transplantation for whatever reason, they can cut the valve out and freeze it and make what's called a homograft because it's the same species we are. And all the other tissue valves come from cow tissue or pig tissue, and since they're not us, they're hetero or other heterografts. The big advantage of tissue valves is, since they're like us, they're made out of roughly the same material we're made out of, they don't clot. Blood doesn't clot on them because they're similar to us. Whereas mechanical valves, not at all like us, you have to take anticoagulation to have them in place. And of course, anticoagulation, while safe, does have its risks. The original of these valves, this is the original 1200 Star series, Star Edwards valves. Al Starr was one of the original heart surgeons. Lowell Edwards made a bunch of money in World War II developing a carburetor that would allow a fighter plane to fly upside down. Because one of the things about fighter planes when they're upside down is the gasoline doesn't go into the carburetor the same way, if you remember the carburetors. And so Lowell Edwards figured this out. He was a brilliant engineer, and the company Edward Life Science is named after him. And he got to know Dr. Starr and wanted to make a company to replace the whole heart. And this is like 1948, 1950. And Dr. Starr pointed out to him they didn't even have a good valve replacement yet. And so they worked on this incredible device, which is actually, it's got problems and it's not used anymore, but it was pretty fair, especially compared to many of the things that followed it. All kinds of wild designs that didn't work. This particular valve is the Bell valve. It was developed by a guy named Bell in Texas, Beall. The problem with this valve is that the poppet wore out because of its banging on these metal struts, and eventually the poppet would jump out of that, and you'd find the poppet down here at autopsy in the patient's femoral artery. It's not a good thing. So in other words, not all the attempts to get valves right were successful, and of course a lot of people died. This is a very famous valve also. This is the Bjork-Schiley valve. Great mechanical valve for its time, early 80s. Most of them are not, there are very few people that have them left in now. Very few people still alive that have them in place. This is the first really, really successful mechanical heart valve. You can see it's a bi-leaflet design. These leaflets move like this. And the key to this valve's design is this pivot. Because if you think about it, how hard would it be for a little tiny clot of blood to make this pivot not work? And the valve would get stuck open or stuck closed. So the design of the pivot was a critical feature of this valve. And the first guys to get it right were this company. And subsequent companies have found other ways to do it. This is the Med-Hall valve, the most successful single disc valve. But no single disc valves exist on the market today because they're inherently less useful. They don't transmit blood as well, and they're more likely to fail than the bileaflet valves. One of the most important things to know about these tissue valves is they're not the tissue of the animal anymore. The tissue has been fixed. It's been tanned just the way your shoe leather is tanned, except it's a much more sophisticated process. And in fact, it's so sophisticated that you can get 360 million bending cycles before it gets stiff. The key thing that happens to these valves even is that the calcium gets in even to the fixed tissue, the tissue that's been tanned. And when the calcium gets into it, they get stiff. And of course, you think to yourself, which breaks sooner? This thing that I'm holding, this little rubber thing on my glasses, or a coat hanger? Well, the coat hanger, of course, if you start flexing it, it's going to break in 6 or 7 cycles, whereas this thing would probably go through 1,000 before it would break. So you can imagine how well designed these tissue valves have to be to get the 300 million plus cycles on them before they fail. The limited durability is an issue, but many people are willing to trade another operation in 10 years for having to take Coumadin every day for 10 years. And this is a bit like the tax issue. Would you like to pay your taxes a little bit every day, or would you like to pay all your taxes 10 years from now? A lot of us, this is a normal psychological state. A lot of us, even if the taxes would be a little higher in aggregate, most people say, I'll wait 10 years. And so here's the original Hancock valve. Tom Fogerty, who's the founder, and he's the guy who hired me into practice. We just celebrated his 80th birthday, and he's one of the great all-time physicians. Tom was already a very wealthy man when in 1970 from all of his tremendous entrepreneurial stuff that he did. When Warren Hancock came to him and said, I got this idea to make a tissue valve. And Tom put up the money to build the first factory in Orange County. And subsequently, that company was sold to Johnson & Johnson. And Tom made another mountain of money. And then he held on to the J&J stock for a whole bunch of years. And for those of you who have held on to J&J stock for a whole bunch of years, that's another whole bunch of money. So Tom, it was his insight that this would work that turned out to be true. And the descendants of this valve are in some of the people in this room today, because eventually Medtronic bought this company, and some of the best tissue valves are the children of the original Hancock valve. This is the pericardial valve. This is this particular one was a disaster, but the one that looks very much like this that was it ended up being made by the Edwards company, the same company that Lowell Edwards started, and is a tremendous success. They look a little bit different, but it's the same idea. And then, of course, the human homograft. When you cut the valve out of a human being who is brain dead, it's got a lot of tissue down here at the bottom. And that tissue makes it very good for fixing the valve of people who have had an infection, an active bacterial infection in the root of their aorta, aortic valve endocarditis. because that infection chews up that tissue. And the extra smushy tissue that's at the bottom of this gives you something that's safer to sew into. So the best use for homografts now is in people, and the only time I use them is in people who have endocarditis. They're stored in liquid nitrogen tanks at minus 190 degrees, and you thaw them out, and it takes about 20 minutes, and they're very, very useful in this setting. As they've evolved, as the tissue valves have evolved, the heterografts have evolved. We figured chemicals to put in them to make them less likely to get calcium in and get stiff, but they still have 10, 15 years. They last longer the older you are when they're put in, because our calcium metabolism slows, and we influx calcium into them much more slowly at our age than when you're 12 or 15 or 20 or 30. So the older you are, the longer life the valve has. This is the one we're currently using, the mosaic porcine valve. Oops. It's you guys that went dead. I'm fine. Here. Oh, there it is. Oh, so here's a valve I found on my phone that I'd taken out of a patient. You can see when they get stiff, of course, the tissue breaks, and then it looks like this. And you can see this patient not only had a valve that didn't open right, but you can see that it had a hole in it too, because of the tissue had just broken after 400 million cycles. Now, surgical technique has gotten better too. And this was a lady that, I just found this in my phone while we were putting this together. That's the upper mini sternotomy, that little incision for doing aortic valve replacement that's still very useful, and it's sort of the gold standard for people who are good enough to undergo an operation, which means they can withstand an anesthesia, that they're in pretty good shape. And although it's very wonderful, as Jim showed you, that the initial results from the critically ill patients that can't have an operation had a 50, or actually in the original paper, 70% one-year mortality if they were not fixed, and about a 40% mortality if they were fixed. The core valve study was more conservative and done later so we could pick the patients better, had about a 50% mortality projected if you weren't fixed, and only a 25% mortality if you were fixed. If even for people over the age of 75 in our own hands, and Conrad and I did this back some years ago when we were getting ready to be in the core valve trial, we looked at 350 patients that we'd done, average age 82, that we'd done over the last few years. And the mortality risk was 2.2%, the stroke risk was 1%. And if you looked out 5 years amongst this patient, 85% of them were still alive at 4 and 5 years. So that if you're in good shape when you're done, the ones that Jim was talking about, where the patient's basically in good shape, they just happen to be in their early 80s or even late 80s, and they have bad aortic stenosis, but the rest of their systems work, they have a very good prognosis. They can be restored. In fact, it sounds screwy, but they actually have a better survival rate than age-matched peers from the general community. So if you look at the mortality curve, I almost put this in the thing, but I thought it'd be too technical. If you look at the mortality curve for people who are in their 80s, and obviously more and more of us die as we get older, that these people it's actually better. And the reason it's better is not because aortic valve replacement confers immortality, but it's because to start out with, they were better 80-year-olds. These were the people who didn't have Alzheimer's disease, they didn't have cancer, they didn't have a lot of other renal failure. So you take an optimal group of 80-plus-year-old patients who have aortic stenosis, do a successful aortic valve on them, and they can go a long time. So let's see what else we have here. And then I won't go through this at all, but this is the next step. This is what Jim was showing you. This is this material Nitinol that he mentioned, that the characteristic Nitinol, nickel titanium National Ordnance Laboratories is what Nitinol stands for. And this is a metal that's been around for a long time. It's a nickel titanium mix. It's a very cool material because when you put it in ice water, it gets limp. So you can build a valve inside it. while it's tumescent, I think would be a nice word for it, and then put it in ice water so it gets limp, and that allows you to stuff it inside the catheter. Then you put the catheter in the patient, and as Jim showed you, and as you release it, of course, it immediately is springy and pushes the old valve out of the way. Very cool material. Jim's already showed you all this stuff. So now, let me just show you our results here. We do a lot of elderly patients. We do a lot of people who have had previous surgery, like many of these patients have had previous coronary bypasses when they're in their 60s, and then come in their 70s and 80s and need an aortic valve done. We have, a lot of these people are older. And of course, in the Bay Area, they're older than the national, because people take better care of themselves in the Bay Area. There's less smoking. You know, there's still a lot of people back east that are actually smoking cigarettes. And we do more re-ops, probably for the same reason, that there are just more healthy people out there that are worth a fight. And we don't take much time to do these cases. You know, our pump times are short because we do a lot of this kind of surgery. I personally have done about 4,000 aortic valve replacements. So sooner or later, no matter how stupid you are, you get better. And then, you know, we've had, again, with a great team, you don't have infections, you don't have strokes. They should be really rare. An occasional patient will bleed despite our best efforts. And I don't know, I can't see. Oh, here's the mortality. Yeah, we have really good mortality statistics doing these cases here because it's such a wonderful group of people working on them. And it takes everybody to do that. It's not just a surgical issue. The person who preps the patient, the way the lines are put in for anesthesia, everything matters. That's why it's such an important team. There's nothing that doesn't matter. Everything counts. It either makes the patient safer or makes the patient less safe. So now let's just go on and do questions. Oh yeah, we have a very high rating to do this operation. Let's go on and do questions about this. Can I answer any questions for you while we're here?
Over here. If you have a question, raise your hand and I'll...
Is the calcium intake, do you have any thoughts on that? Because if you take too much calcium, then, you know does it deposit?
In general, if you have a pig valve in place, you shouldn't take calcium supplements. It's said generally. Nobody really has a good science about that, where they've done a randomized controlled trial with some people taking calcium supplements and other people's not. In general, probably being my mother's child, I'm a great believer in not taking any of these things. I just eat like an Italian. Remember, most of those people were too poor to have a lot of meat, so that's not stupid. And they also used a lot of olive oil. Stay away from the animal fats.
I have a question. Friend of mine have the human valve replacement, yeah, and has been 20 years now, but he's doing well. He did not take any medication. You understand the question? There's a patient who's a friend here who has had a valve in for 20 years. It's a homograft. Valves are just like people. Some of them live to be 90. 90 for a homograft is 30 years. So the average homograft won't last that long, but there are homografts that will. And by the way, there are pig valves that'll last 27 and 30 years too. Eventually, they usually fail. And depending on the age of the patient either outlives the valve or the other way around. But now he's in his 60 now, and he start having, have no symptom of SOB,
Right.
But the thing is, he went to a cardiologist recently. The doctors did some tests and say have a severe leakage.
Yeah, right. So the leakage means, that again, this piece right here of my 3-piece valve is beginning to tear and loosen. He's not symptomatic yet because he's not leaking badly enough, but he will. And so, sometime in the next few months, he needs to be reoperated.
Right.
The reason we don't like homografts to begin with is because it's a little more complicated to hammer them out the second time around.
So in other words, the reason I wouldn't put a homograph in one of you, just right off the top of my head, is because you may live long enough so that the next dumb son of a bitch who goes in there will have trouble taking it out. That's a key feature. Always make it easy for the next dumb bastard because he may be you.
Right. So now he was thinking about, the doctor said. It's
one of my favorite thoughts.
Yeah. In that case, if he has symptoms, the doctor will say, go ahead and do the replacement.
Yeah, even
But-
maybe before he has symptoms. What you watch for in that case is you look for symptoms, very, very important, and you look for whether his heart's stretching out. Because like I explained to you, if he's having to beat so much that his heart keeps getting larger and larger, they can bag out his equipment before he even, and we're very variable that way, we human beings. Some of us get symptoms before our heart gets enlarged, and some of us get very enlarged hearts before our symptoms get bad. And that's because nature didn't predict, nature didn't give us the equipment to get this accurate. The way we were designed was to be pretty functional until we dropped. We don't feel 10% bad when we're 10% sick and 20% bad when we're 20%. We usually feel okay until we're very ill. Wouldn't have nature have made us that way? Because what good would we have been, sort of slightly out of whack? So we're capable of, by psychological and by physical being, capable of keep going until near the end. We're cliff vested in our own lives, is the way to think about it.
So he was just thinking about, when to do that.
Yeah, well, I would be very guided by how big his heart is on echo. And the other thing that I do all the time with these patients is I say, oh good, you think you're asymptomatic? Fine, here, go over to Dr. Ramahan or Dr. Joy, get on a treadmill and show me that you can do normal exercise for a person your age. So if the guy's 65, he ought to be able to go about 9 minutes of what's called a regular Bruce protocol.
He passed that test.
If he did, then good. The doctor's doing just the perfect thing with him then. He's asymptomatic, you just watch his LV size, and within the next year or so, he's going to, whether it's 6 months or a year, I don't know, but he'll be coming for operation.
Okay.
Questions? Right here.
Is there any kind of rejection by using a homograph?
No, the reason most of the cells are killed by the freezing, and it's the law. As soon as the cells become non-vital, a lot of the immunological response goes away. It's very interesting. Same thing with the tanning the leather before in a heterograph. It takes away the immunologic, most of the immunologic features of the valve. There may be some minor ones, but nothing like me trying to put my skin in a hole on your skin, which you would immediately reject in 4 or 5 days.
Questions?
Thank you all very much. It was fun.
So Dr. Gaudiani was very humble, but that last slide he showed really speaks to just how successful the program is here and his experience over many decades.